Hello, and a very warm welcome to everyone joining today. I am Dr. Sakin Saleh Ifti. Today we'll study one topic completely, that is stable angina under ischemic heart disease. Before we start, let me tell you one thing very clearly. In AMC Part 1, the correct answer is not always the answer you learned in your medical school. The correct answer is the answer that Australian practice accepts. Let me give you a simple example. A patient with stable angina comes to you. In many countries, the first thing many doctors think is send for angiogram, put a stent. In Australian guidelines, for stable angina, the first step is medicine and risk factor control. Stent is not the first answer. So if you study from a random source, you may lose marks even when your medical knowledge is good. That is why every line in today's class comes from Australian sources. It would be from therapeutic guidelines, the Australian Acute Coronary Syndrome Guideline by Heart Foundation. It would be from John Murtag's General Practice 9th edition, and some of the references have been taken from Davidson's Principle and Practice of Medicine, 25th edition. Nothing is invented here, nothing is copied from a random website. Now, our fourth batch of the AMC Part 1 Mastery Program starts on 15th September 2026. It would be covered in 6 months, 6 modules: Medicine 1, Medicine 2, Medicine 3 with surgery. There will be Paediatrics with Psychiatry. There will be Obstetrics and Gynaecology. And finally, Biostatistics, Epidemiology, Ethics, and others. In every module, you'd get live classes that would be super interactive. I'll provide class recordings later on. There would be high quality class notes. One important thing is that there will be integrated e-medicine question bank with simplified explanations. I'll show to you later on. Management from Australian guidelines, scenario-based question solving. There would be regular assessments, a full 150 questions mock exam, and one-to-one progress discussion. Fees are 325 Australian dollar for the full program, or $65 per module. For Bangladeshi participants, it would be 24,500 taka full, or 5,200 taka per module. Early bird discount ends on 10th September 2026, and you save around 100 Australian dollars. Seats are limited. You can WhatsApp us on the number on the screen for any enquiry. Now give me 2 minutes on this slide because it explains exactly how we teach. There are 6 parts here and each one has a different job. You can see this is the master note. This is your main study material. We collect everything from the Australian guidelines and the trusted clinical books and bring it into one note, topic by topic. So you do not open therapeutic guidelines, then Murtagh, then Davidson, then some random website at midnight. One topic, one note, one place. Then there is this revision note. This is not the same as the master note. This one is short, only the key facts, tables, flowcharts, mnemonics. This is what you read in the last few days. When there is no time left for long paragraphs, I'll show you one at the end of today's class. Now, very important thing is this QBank integration. You know, e-medicine is the closest question bank to the real AMC Part 1 exam currently. But there is one problem with it. The questions are mixed. Today, cardiology, next question might be pediatrics, then ethics. Your brain jumps from topic to topic and nothing stays. Even if you choose to only solve the cardiology questions, the topics would be very scattered, random. So we sort them topic by topic and teach them right after the concept with simplified explanations. When you solve 10 questions of the same topic, one after another, you start seeing the pattern the examiner uses. That pattern is what actually gets you through the exam. Now, regarding assessment, after every topic and after every module, a short test. Not to give you a mark, to show you which topic is weak while there is still time to fix it. We'll take a full-length exam in real exam conditions. Because knowing the answer and sitting for 3.5 hours and staying calm are two completely different skills. Finally, one-to-one discussion. Personal time with me for your doubts and for your study plan because every candidate's situation is different. Other than this, you can contact me 24/7. I'll try to get back to you as soon as possible. So today's free class is a sample of three of these: the master note, the QBank integration, and the revision note as well. Okay, I'll start with one question just to show you how we integrate e-medicine questions in our classes. I'll give you 30 minutes to go through this question. I'm sorry, 30 seconds. Quite a long stem, right? So it would take much of our time. So let's simplify this. Here is the simplified version. This is how I want you to read every question in the exam. I do not need all the information from this stem. I need these bullet points, pieces that will lead me towards the answer. So this 75-year-old male with 3-month history of central chest discomfort on walking quickly, which resolves completely with rest. So this kind of gives us a vibe of stable angina. He has similar pain today, currently pain free. He has some comorbidities, one of them is CKD. His drug history is given, examination findings normal. We can see his creatinine is 210, which is way above the normal range. So his kidneys are weak. Trop I, it has been 38 at the beginning, then 42 after 6 hours. Slightly above normal, but almost no change between the two. And there are two ECGs, one from today. The first image is from today. The second image from 2 years back. We have been given 5 options: coronary vasospasm, stable angina, unstable angina, ST elevation, MI, non-ST elevation, MI. So the answer is stable angina. Let me give you only the key points because the full logic will make complete sense when we do acute coronary syndrome in the next class. Point number one, the pain comes with walking and goes with rest. And it has been saying for 3 months. That is a stable pattern. Point number two, and first one word. Troponin is a protein inside the heart muscle cell. When the muscle cell dies, this protein leaks into the blood. So we use it as a marker of heart muscle damage, and it is cleared from the blood by the kidneys. Now look, troponin was 38, then 42. So there has been a rise of 4, which is less than 6. In a real heart attack, the troponin does not creep, it jumps. And in chronic kidney disease, the kidney cannot clear it, so the level stays mildly high all the time. So this is his chronic baseline, not fresh damage. So you can repeat after me. In chronic kidney disease, a mildly raised troponin that barely changes is a chronic baseline. A heart attack gives a rising pattern, not a flat one. Point number three is ECG. His ECG shows left bundle branch block. We'll talk about them in a very effective ECG masterclass that you will have when we start the course. But for now, we'll have to look at the V1 and we can see this deep S wave, and the QRS is definitely more than 120 uh, 120 milliseconds in width. So this quite meets the criteria of LBBB. Now that means the electrical signal cannot travel down the left branch normally, so the left ventricle contracts late, and this completely changes the shape of the QRS and the ST segment. That is the problem. Once there is left bundle branch block, you can no longer read the ST segment in the usual way. But look at the ECG from 2 years ago. The same block is already there. So it is old, not new onset. And when the block is there, we use a set of rules that are called Garbosa criteria. There has been a modified version, so modified Garbosa criteria, to decide whether a heart attack is hiding behind it. Here, those criteria are not met. We'll talk about them later on. So a stable story, a flat troponin, and an old ECG change. Everything points to stable angina. Notice one thing, that 2-year-old ECG saved this patient from an unnecessary trip to the cath lab. This is why comparison with an old ECG is such a favorite of examiners. We'll come back to this style of question in acute coronary syndrome. For now, let us build the concept. Okay, so let us learn the definition of ischemic heart disease. This part has been taken from up to date. First, two words that will come again and again today. Ischemia. So ischemia means the tissue is not getting enough blood. So it is not getting enough oxygen, not dead yet, but starving. If the starving continues long enough, the cells die, and that is called infarction. So ischemia is reversible, infarction is not. That single difference is the whole difference between angina and a heart attack. Now the definition. Ischemic heart disease means the heart muscle is not getting enough blood because of obstruction of the epicardial coronary arteries, the big arteries running on the outer surface of the heart. That is it. Inadequate supply of blood to the myocardium due to obstruction of the epicardial coronary arteries. Now, how do we divide it? Very simply, by the pattern of symptoms. If the symptoms are new or increasing, that is ACS or acute coronary syndrome. If the symptoms are chronic, the same as before, this is stable angina. This has been taken from therapeutic guidelines. So repeat after me. New or increasing means acute, same as before means stable. Half of your cardiology questions are decided by that one line. Now look at this tree, top to bottom. Coronary ischemic syndromes split into two, stable angina and acute coronary syndromes. Acute coronary syndromes split again based on the first ECG. ST elevation present, it is ST elevated MI, a medical emergency. No ST elevation, we call it non-ST elevated acute coronary syndrome. Then non-ST elevated acute coronary syndrome splits one more time based on the troponin. Troponin up, non-ST elevated MI, meaning muscle has died. Troponin normal, unstable angina, meaning the muscle was starving but did not die. So remember the order. The ECG decides the first split, and tropi decides the second split. Today we stay on the left side of this tree, stable angina. Now let's learn about stable angina. Angina is a chest discomfort behind the breastbone. The word is retrosternal. Retro means behind, sternal means the sternum. That lasts 10 minutes or less and settles promptly with rest. So why does it happen? Because the heart's oxygen demand becomes more than the supply, and the supply is limited by atherosclerotic obstruction, that is a fatty plaque inside the artery wall that has made the pipe narrow. It is usually brought on by physical activity or emotional stress. Now this second line, and this is the exam line. Angina is called stable if the pattern has not changed in the past 1 month or so on. Same distance of walking, same amount of effort, same relief. So stable means the pattern is unchanged for the past 1 month or more. When the exam stamp says for 3 months, unchanged, the examiner has already told you the answer. Take this gift. The words the patient uses change the probability of her disease. Central, squeezing, gripping, tight, heavy, comes with exertion, spreads to arm, neck, jaw. So there is high probability. But if it is described as sharp, shifting, fleeting, hoarse with breathing in, hoarse when it changes position, there is low probability. So, quick clinical tip you can use in real life. If the patient points to the pain with one finger, it is usually not cardiac. If he shows it with a whole fist on the chest, take it seriously. Now the classic picture in points. This is taken from John Murtagh. Angina is an oppressive discomfort rather than a sharp pain. Oppressive means heavy, pressing feeling, like something sitting on the chest. This matters because many patients will say, Doctor, it is not pain, it is heaviness. And a junior doctor writes, no chest pain in the notes. That is how heart attacks get missed. It is transient, less than 10 minutes. It is retrosternal, and it can radiate to arms, jaw, throat, and back. Radiates means the pain spreads out from the chest to those places. It may come with shortness of breath, nausea, fainting, or sweating. It occurs during exercise, emotion, after meals, or in the cold. Why after meals? Because after a big meal, blood is diverted to the gut, so less is left for the heart. Why in the cold? Because cold makes the vessels constrict, and it is relieved with few minutes with rest. The important differential diagnoses are mitral valve prolapse, esophageal spasm, and dissecting aneurysm. Now, the mechanism in one simple story. Please follow this because every drug we discuss later works on one of these steps. Plaque forms in the artery wall. The artery becomes fixed and narrow. The word for that narrowing is called stenosis. You can see the stenosis right here. At rest, the blood flow through the narrow pipe is still enough, so the patient sits at home perfectly comfortable. Now he climbs the stairs. His heart beats faster and harder, so it needs more oxygen. But the narrow pipe cannot deliver more. Demand goes above supply. The muscle becomes ischemic. The ischemia stimulates pain receptor, and he feels the chest discomfort. That patient then stops walking, demand comes down, supply is enough again, pain goes away. That is the whole disease in one paragraph. And now you can predict the treatment yourself. Either we bring the demand down that is beta blocker and calcium channel blocker, or we improve the supply, that is nitrates, stent, and bypass surgery. There is no third option. Two extra lines from the Australian ACS guideline. The pain radiates to the neck, arm, jaw, is brought on by exertion and relieved with rest after 15 to 20 minutes. So in therapeutic guidelines, it was under 10 minutes. In John Murtagh, it was under 10 minutes, but ACS guideline Australia says it can be up to 15 or 20 minutes. And very important point is that chest pain is not always present. Some patients, especially the elderly, diabetic, or women, come only with breathlessness, sweating, or sudden tiredness. We call that an angina equivalent, the same disease wearing a different mask. Why do diabetics not feel the pain? Because long-standing diabetes damages the nerves. We call this autonomic neuropathy, so the pain signal never reaches them properly. That is called silent ischemia. Angina does not always mean a blocked artery. Look at these causes. Notice how each one fits our supply and demand story. The coronary artery atheroma, this is the common one. Supply is blocked. Regarding valvular lesions, especially aortic stenosis, the valve is tight, so the ventricle has to squeeze much harder against it. Demand goes up and the thickened muscle also needs more blood. Rapid arrhythmias. A very fast heart needs more oxygen and it also has less time to fill. Remember, the coronary arteries fill during diastole, the relaxing phase. Fast heart means the diastole is shortened, meaning less coronary filling. Demand up and supply down together. Anemia. The arteries may be perfectly clean, but the blood itself is carrying less oxygen. Supply down here. And the rare ones like vasculitis, trauma, collagen disease. The note at the bottom is a classic exam trap. Look for fever and tachycardia and rule out anemia and thyrotoxicity. So before you label a patient angina, start a beta blocker, check the hemoglobin and listen for a murmur. Now the risk factors, the usual ones you already know: age over 75, diabetes, hypertension, high cholesterol, obesity, smoking, socioeconomic disadvantage, family history of early heart disease, meaning a male first degree relative under the age of 55 years or a female under the age of 65 years. Now listen to the ones students miss. Chronic kidney disease, severe mental illness, chronic inflammatory conditions like psoriasis, rheumatoid arthritis, lupus, systemic sclerosis, because long-term inflammation damages the vessel lining. Familial hypercholesterolemia, ethnicity, South Asian or First Nations ancestry. This matters to you personally and the Australian guidelines mention it directly. So for women, early menopause and pregnancy related conditions such as preeclampsia, gestational diabetes, and to modern ones, a high polygenic risk score, and COVID-19 infection. Before you diagnose angina, remember these can copy it exactly: anemia, valvular heart disease like aortic stenosis, thyrotoxicosis, and hypertrophic cardiomyopathy. So a careful history is your main test. Now the family of anginas. Know the name and one line each. Stable angina. Pain with exertion, predictable, no change in the past month. Unstable angina. Increasing in severity and duration over a short time. Coming with less and less effort, and it may come at rest, especially at night. It is due to an unstable plaque, meaning the surface of the plaque has cracked and a clot is forming on it. That is why it is dangerous. Another word you will meet is crescendo angina. Crescendo means getting bigger, so it is the same thing as unstable angina. Now, nocturnal angina, pain during the night, it belongs to the unstable family. Decubitus angina, pain when lying flat, relieved by sitting up. Variant angina, also called fringe metal angina or spasm angina, pain at rest without any cause, and the ECG shows temporary ST elevation, not depression. It is caused by spasm of the coronary artery, meaning the muscle in the artery wall suddenly squeezes shut. The last one is microvascular angina. The smallest vessels are affected, so the big arteries look completely fine on angiogram, but there is problem in the tiny ones. Previously, we called these cardiac syndrome X. So, exertion with ST depression, it can be ordinary angina. Rest with ST elevation that comes and goes, it can be fringe metal. Regarding the investigations, ECG first. In stable angina, the resting ECG made completely normal, or it may show ischemia or evidence of an early infarction, meaning old Q waves. From a heart attack he may not even know he had. During an acute attack, it may still be normal, or it may show well-marked depression of the ST segment, symmetrical T-wave inversion, or tall, upright T-waves. The next one would be exercise ECG. If the ECG is normal or it suggests ischemia, we can proceed with exercise ECG. Here we make the patient walk on a treadmill and watch the ECG because the disease only shows itself when demand rises. It is positive in about 75% of patients with severe coronary artery disease. We use it when the diagnosis is in doubt for prognosis and to decide the timing of further testing such as angiography. A normal stress test doesn't rule out coronary artery disease. There is still 25% case left. So this is the typical picture ST depression during an attack. Why depression here? And an elevation in a ST elevated MI. Simple idea. In angina, only the inner layer of the muscle, the layer furthest from the blood supply is starving. That is the subendocardial area. That gives ST depression. In ST elevated MI, the artery is completely blocked and the full thickness of the wall is affected. That gives ST elevation. Now read the note under the figure. There is no specific ECG of angina. The most we can say is that the ECG is consistent with angina. This is taken from John Mottag. So a normal ECG never excludes angina and a normal stress test does not rule out coronary artery disease either. Here we can see three shapes of ST depression. First one is planar, that means flat. It means ischemia. Panel B shows downsloping. It is also ischemia. Panel C shows upsloping, maybe a normal finding. So easy way to hold it, flat or going down is bad news, going up is usually fine. And on this side, we can see a positive exercise test. The resting ECG, that would be these ones, showed some minor TOF changes in inferolateral leads. That would be this one, okay? But otherwise normal. After 3 minutes, exercise on a treadmill, there is marked planar ST depression in lead V4 and V5. We can see there has been huge changes. Subsequent coronary angiography revealed critical three-vessel coronary artery disease. Now there are some other tests that John Mottag mentions. Exercise thallium 201 scan. Thallium is a radioactive tracer that is only taken up by muscle that is actually receiving blood. So the area that light up are alive and perfused, and the dark areas are not getting blood. Why do we need it? Because if the baseline ECG is already abnormal and you cannot judge exercise changes on it, so we look at the blood supply directly instead. We can use it in left bundle branch block, in old infarction, in WPW syndrome, and in mitral valve prolapse, which gives many false positive stress tests. Next one is Holter monitoring, a small ECG recorder on for 24 hours or more for intermittent rhythm disturbances that a short ECG in your clinic will always miss. Next one is gated blood pool nuclear scan. It measures ejection fraction, meaning the percentage of blood the left ventricle pushes out with each beat. Normal is about 50%. It helps assess a patient for bypass surgery. And the last one mentioned here is echocardiography. It shows global and regional wall motion abnormalities, valve dysfunctions, and the pericardium. So, regional wall motion abnormality means one segment of the wall is not moving properly, and that segment tells you which artery is diseased. Now, coronary angiography. It means passing a catheter to the mouth of the coronary artery, injecting dye and taking X-ray pictures. It accurately shows the extent and severity of coronary artery disease, and we use it mainly to map the arteries before any procedure. CT angiography is a safer alternative in many situations because nothing is passed into the heart. It is just a CT scan with contrast. And one honest line, the relationship between how bad the angina feels and how bad the arteries look is not straightforward. Some people with severe angina have normal coronary arteries. Here we can see coronary angiogram of left coronary artery with a huge stenosis in the proximal LAT. And the circumflex artery has two moderately severe stenosis. On this side, we can see the coronary circulation. We can see from the aorta, this left main coronary artery arises, and then it is splitted into left anterior descending artery, this one, and left circumflex coronary artery, this one. Right coronary artery also arises from the aorta and it moves down here. Okay, we'll talk about this anatomy again when we go through the ACS topic. Now, indications for angiography. When do we send for angiography? Strong positive exercise stress test, suspected left main coronary artery disease, angina that is resistant to medical treatment, suspected angina but are not otherwise proven, acute coronary syndromes, angina after a heart attack, and patients over 30 years with valve disease going for valve surgery. Look carefully at the first two, a strong positive stress test and suspected left main disease. Keep them in mind because the first emergency question at the end depends on exactly this. Treatment of stable angina has two separate jobs. Keep them in two separate boxes in your mind because examiners test whether you can tell them apart. Job 1, treat the episode when the pain comes. Job 2, prevent the episode from coming. And behind both, we control the risk factors. elevated blood pressure, smoking, cholesterol, exercise, healthy eating, body weight, diabetes. Two more things that students forget. Screen the patient for depression and treat it, and give the annual influenza vaccine plus pneumococcal and other vaccines. Why vaccines in a hard topic? Because a severe chest infection puts a big strain on a heart that already has a poor blood supply. So regarding general advice, reassure the patient because angina has a reasonably good prognosis if it is stable. If he is inactive, start walking around 20 minutes per day. Take regular exercise up to the threshold of angina, meaning exercise up to the point just before the pain starts, and stop there. Over weeks, that threshold rises. Offer stress management if he is tensed. Avoid precipitating factors like heavy, sudden, unaccustomed exertion, cold weather, heavy meal, etc. And this one matters. Do not tell him to stop living. Do not excessively restrict his lifestyle. Now, job one, treating the episode. When the pain starts, first, stop the activity. Sit down. That alone lowers demand. Then, glyceryl trinitrate, our famous GTN. How it works? GTN is converted in the body into nitric oxide, which relaxes the smooth muscle in the vessel wall. It relaxes the veins most of all. So less blood returns to the heart. That is called reduced preload. So the heart is less stretched. It has less work to do and oxygen demand falls. It also opens the coronary arteries a little, so supply improves. Demand down, supply up, pain settled. Why under the tongue? The area under the tongue has a very rich blood supply, so the drug is in the bloodstream within a minute and it escapes being destroyed by the liver first. A swallowed GTN tablet is useless. So we can use it either in spray form, it would be 400 to 800 micrograms sublingually. Repeat every 5 minutes if pain continues. Maximum 3 sprays, that is 1200 micrograms. Or tablet 300 to 600 micrograms sublingually. Repeat every 5 minutes, maximum 3 doses. So 1800 micrograms. A nice detail for a patient having his first ever episode, use the lower dose, either 400 for spray or 300 for tablet. For established angina, the higher doses, 800 for spray, 600 for tablet. You can repeat it after me. If the pain continues more than 10 minutes after 2 doses of GTN, I'll ask my patient to take the third dose and call an ambulance for transfer to hospital, because now we must think heart attack, not just stable angina. Side effects: headache. It is the commonest side effect because it dilates the vessel in the head also. Tell the patient in advance and he will stop the drug otherwise. Also, patient might experience flushing, dizziness, fall in blood pressure. That is exactly why he must sit down before taking it to avoid orthostatic hypotension, meaning the blood pressure drops when you are upright and blood pools in the legs. If he takes it standing, he might faint and fall. An elderly man with a fractured hip from a chest pain that would have settled anyway is a very bad outcome. Now, our favorite Murtag adds aspirin 150 milligram orally for the acute attack. Why aspirin? It blocks the enzyme COX-1 in the platelet, so the platelet cannot make thromboxane A2. So platelets become less sticky and a clot is less likely to form on the plaque. Now carefully, if we note, aspirin does not relieve the pain. It prevents the clot. Regarding side effect, it can cause GI irritation, ulceration, bleeding. And if the patient cannot tolerate nitrates, the alternative is nifedipine 5 milligram capsule, sucked or chewed form. Now there are some GTN tips. Keep the tablets away from light and heat. Discard the bottle 3 months after opening, or 2 days if it is carried on the person, because body heat destroys the drug. So the tablet sitting in his shirt pocket for 6 months is a dead tablet, and he will think his angina is getting worse. So do not give nitrates if the patient has taken sildenafil or vardenafil in the last 24 hours, or tadalafil in the previous 5 days. Why? Because both are vasodilators working on the same pathway. So together they cause a severe and dangerous fall in blood pressure. So picture this: a 60-year-old male in your emergency department with chest pain. Before you hand him GTN, you ask quietly and politely about erectile dysfunction tablet, Viagra. That one question can save his life. Examiners love this concept. Now let's move on to job 2, that would be preventing the episode. Prevention has two parts. Do not mix them. First, the drugs that protect the artery and reduce future heart attacks, aspirin and statin, plus treatment of elevated blood pressure. These do not stop today's pain, they protect his future. A word on the statin: it blocks the enzyme HMG CoA reductase in the liver. So the liver makes less cholesterol, LDL falls, and the plaque becomes more stable and less likely to rupture. Side effects to remember: muscle ache, rarely severe muscle breakdown, and deranged liver enzymes. If a patient on a statin complains of muscle pain, take it seriously. Secondly, anti-anginal drugs, the ones that actually stop the pain coming. The rule: start with a single anti-anginal drug. If that is not enough, combine two drugs from different classes: beta blocker, dihydropyridine calcium channel blocker, and long-acting nitrates. If a beta blocker is contraindicated, replace it with non-dihydropyridine calcium channel blocker, and the choice depends on the patient's comorbidities and the adverse effect of the drug. So, in short, one drug first, then two drugs from different classes, then specialist advice. Never jump to the third step in an exam question. Now, beta blockers. They are usually first line to prevent episodes of angina, unless contraindicated. They also reduce the incidence of recurrent MI. How do they work? The heart has beta 1 receptors. Adrenaline acts on them to make the heart beat faster and squeeze harder. The beta blocker sits on these receptors and block that. So heart rate and force of contraction both fall. Demand goes down. And there is a second beautiful benefit. The coronary arteries fill during diastole, the relaxing phase. A slower heart means a longer diastole, so the coronaries get more filling time. So a beta blocker reduces demand and improves blood supply. That is why it is first line. Dosing: atenolol 25 milligram orally daily up to 100 milligram, or metoprolol tartrate. You can see the dose here. Regarding side effect, it can cause bradycardia, tiredness, cold hand and feet, erectile dysfunction, a common reason men quietly stop taking this tablet, vivid dreams, and in diabetes, it can mask the warning signs of hypoglycemia because the tremor and palpitations that warn them are adrenaline signs. The key contraindication for beta blocker would be asthma. The lungs have beta 2 receptors that keep the airways open. Non-selective beta blockers can block those too and cause bronchospasm, that is tightening of the airway muscle. You will see this in question number 4. And never stop a beta blocker suddenly. The receptors have become extra sensitivity. So you get rebound angina. So there are two warnings from the guideline, from therapeutic guidelines. Do not combine beta blocker with verapamil or diltiazem without specialist advice because both slow the heart and together they cause severe bradycardia and heart failure. And with left ventricular dysfunction, where ejection fraction is 40% or less, do not use atenolol or metoprolol tartrate. Use the heart failure beta blockers like carvedilol, bisoprolol, nebivolol, or metoprolol succinate. Now, calcium channel blockers. One line of basic science makes this whole slide easy. Muscle needs calcium to contract. Block the calcium and the muscle relaxes. But there are two families acting on two different muscles. Separate them clearly. Family 1 is non-dihydropyridine calcium channel blockers, verapamil and diltiazem. These act mainly on the heart muscle. and the conducting system. So they slow the rate and reduce the force, exactly like a beta blocker. That is why they are the alternative when a beta blocker is contraindicated or not tolerated. For example, in your asthmatic patient, there is also uh, in an asthma patient, you can use these non-dihydropyridine calcium channel blockers instead of beta blocker. There is also evidence of benefit after a myocardial infarction in patients without heart failure. You can see the doses here. Regarding side effect, they can cause bradycardia, heart block, worsening of heart failure, constipation, especially verapamil. And you'd like to avoid both if the ejection fraction is 40% or less because they weaken an already weak pump. Family 2 is dihydropyridine calcium channel blockers, for example, amlodipine, nifedipine. These act mainly on the arteries, not on conduction. They open the arteries, so the pressure the heart pumps against the afterload falls and the heart's work falls. They also dilate the coronary arteries. Here is the contrast, and it is the single most tested point in angina pharmacology. Verapamil and diltiazem slow the heart, so never combine them with a beta blocker. On the other hand, amlodipine and nifedipine do not slow the heart, so they are safe to add to a beta blocker. That is why the guideline says a dihydropyridine can be added to a beta blocker if angina persists. You can see the dosing. Regarding the side effect, they can cause ankle swelling, the classic one, because the small arteries dilate and fluid leaks into the tissue, plus headache and flushing for the same reason. One caution from the guideline: used alone, they can trigger a reflex rise in heart rate. We call this reflex tachycardia because the body senses the drop in pressure and speeds the heart up. And a faster heart means more angina, which is another reason they pair so well with a beta blocker. The beta blocker cancels that reflex. Now, nitrates to prevent angina. We already know the mechanism: venodilation, less preload, less demand. A short-acting GTN can be taken before an activity likely to provoke angina. So if the heel on the golf course always brings the pain, one spray before he starts and he plays comfortably. Remember this, it is the answer to question number 4 that we'll see in a moment. A long-acting nitrate, a transdermal GTN patch, or modified release isosorbate mononitrate can be added to a beta blocker or to verapamil or diltiazem. Now the concept that gets tested: tolerance develops rapidly. Tolerance means the body stops responding to the same dose. So keep nitrate in the blood 24 hours a day, and within days it simply stops working. That is tolerance. The solution is a nitrate-free period. Isosorbate mononitrate once daily, or the patch on less than 14 hours per day. So patch on in the morning, off at night, and the receptors reset. So we need to remember one more thing, that is long-acting nitrates relieve symptoms but do not improve survival. Aspirin and statin protect life. Nitrates protect comfort. You can see the dosing here. Side effect, always headache. If two antianginal drugs are still not enough, other drugs can be added and seek specialist advice. The word for this situation is refractory angina, meaning symptoms continue despite proper treatment. You can use nicorandil for that, added to a beta blocker, diltiazem or verapamil. It works two ways at once. It opens potassium channel, relaxing the arteries, and it has a nitrate-like action on the veins. You can see the dosing here. The side effect worth remembering is ulceration. It can cause mouth ulcer and ulcer anywhere in the gut. A painful mouth ulcer that will not heal in a patient on nicorandil is the drug. Parhexylene for patients who still have angina despite optimal medical management and revascularization, or if revascularization is contraindicated, including when the patient refuses the procedure. It needs blood level monitoring because too much causes nerve and liver damage. And the newer agents, ranolazine, it is recommended by John Mottag. So these are to be prescribed by specialists. So we need to remember the hierarchy: one drug, two drugs, then specialist. In most of the cases, nicorandil is never the first answer. Now the procedures. The general word is revascularization. That means restoring blood flow to muscle that is starving. Percutaneous coronary intervention, PCI. It is the gold standard. Percutaneous simply means through the skin with no surgical cut. A thin tube is passed from the wrist or groin up to the coronary artery. A balloon is then inflated at the narrowing to squash the plug open. That step is PTCA, percutaneous transluminal coronary angioplasty. Then a small metal mesh tube, a stent, is left behind to hold the artery open. Two complications: acute coronary occlusion, meaning the artery closes during the procedure, and restenosis in about 30% within the first 6 months, meaning the artery narrows again because healing tissue overgrows inside. Now, a very important concept because it changes how you answer questions. Stents reduce angina symptoms in stable angina. They reduce deaths and heart attacks in acute coronary syndrome. So in stable angina, comfort only, but in acute coronary syndrome, it is life-saving. So in stable angina, medicine comes first. The stent is not the first answer. PTCA followed by stenting is the most favored procedure to keep the vessel open. We may use a drug-eluting stent. Eluting means slowly releasing, coated with pimecrolimus, sirolimus, or paclitaxel, which stops tissue overgrowing inside, or a plain bare metal stent can also be used. Every stent patient needs long-term antiplatelet agents. That would be aspirin plus clopidogrel because a metal surface inside an artery attracts platelets and a clot inside a fresh stent is a disaster. Clopidogrel blocks a different platelet receptor from aspirin, so together they are stronger. Now, coronary artery bypass grafting. Here the surgeon does not open the blocked artery at all. He goes around it, taking a vein, usually the saphenous vein from the leg, or the internal mammary artery from inside the chest wall, or both, building a new road from above the block to below it. Sometimes with end arterectomy, meaning the plaque is physically stripped out. Symptomatic patients with significant left main coronary obstruction should undergo bypass surgery, and patients with two or three vessel disease with good left ventricular function are considered for angioplasty or surgery. Why is left main disease so serious? Because that one artery supplies most of the left ventricle. A block there puts the whole pump at risk. So left main disease, think bypass surgery. Now, one quick comparison between PCI and CABG. We need the complications mainly. Neurological complications are common after CABG, along with diffuse myocardial damage, infection. After PCI, the problems are we might need to do emergency CABG and vascular damage at the access site. Now let's do the question practice. Before the questions, let me hammer the 6 lines that decide most stable angina questions. You can say them with me. It stays unchanged for a month, but if there is new or increasing pain, it can mean acute. A normal ECG does not exclude angina. Beta blocker is first line unless there is asthma. Never verapamil or diltiazem with a beta blocker. For beta blocker, amlodipine can be a safe partner. Long-acting nitrates need a nitrate-free period and they do not improve survival. In stable angina, medicine first, stent relieves symptoms, it does not save life. Now, let us apply this knowledge. I'll use the simplified form of each question. So this is the main question and the simplified version will be like this. So a 60-year-old male, chest pain on walking uphill, relieved by rest for several months, so stable. Some risk factors like hypertension, high cholesterol. Exercise stress test shows ST depression in lead 2-3 AVF, so the inferior leads at 4 minutes. 4 minutes is a low workload. The pain came very early, meaning even a small rise in demand caused ischemia, so the narrowing must be significant. What is the most appropriate next investigation? The answer is invasive coronary angiography. Typical angina plus a positive stress test at a low workload means a high chance of significant obstructive disease. So we go and look at the arteries directly and decide whether he needs revascularization. CT coronary angiography is for when the diagnosis is uncertain or the likelihood is low to intermediate. We'll talk about the likelihood in the ACS topic. Now, echo and resting ECG cannot show you a coronary narrowing for obvious reasons. and thrombolysis belongs to selected ST elevated MI patients. This man is not having a heart attack. Okay. Now, here is another question. Let's look at the simplified version. 58-year-old woman, central chest pain that is quite predictable on hills or stairs, gone within 5 minutes of rest. This has been for 3 months. No rest pain, no night pain. Smoker. ECG shows TOF flattening in V4 to V6. Troponin 8. Normal range is 0 to 14. What is the diagnosis? Very simple. Stable angina. The pattern is predictable and settles with rest. No rest pain, no crescendo, so not unstable angina. The troponin is normal, so no muscle has died. That rules out non-ST elevated MI. There is no ST elevation, so no ST elevated MI. And fringe metal happens at rest from spasm. Now see the trap they set. T wave flattening. A non-specific ECG change often frightens the student into choosing something acute, but normal biomarkers with non-specific ECG changes are common in stable angina. Do not let a soft ECG finding override a clean history. Now here comes question 3. Let's look at the simplified version. 60-year-old male, exertional chest pain for 6 months, relieved with rest, already on GTN spray and taking atenolol. Which additional anti-anginal? The answer would be amlodipine. He is already on a beta blocker, so we add a drug from a different class that is safe alongside it. Amlodipine is a dihydropyridine. It dilates the vessels and it does not suppress the conduction system. Verapamil and diltiazem are the wrong answers here. With a beta blocker, they can cause bradycardia, AV block, and heart failure. Carvedilol is just another beta blocker, so you would be repeating the same class. And nicorandil is reserved for refractory symptoms. He has not even had 2 drugs yet. Now, this is the fourth question. We can see the simplified version here. 75-year-old male, 3 years of exertional chest pain, completely unchanged, happens once every 2 weeks when climbing a hill on the golf course. Gone within 7 minutes of rest. The pain never occurs at rest. He has asthma. Blood pressure is normal. Angiogram was done last year and it showed 70% stenosis in a small distal right coronary artery that was managed medically. So what is the most appropriate initial step? That would be to recommend GTN prior to exercise. Look at how beautifully the stem gives you the clues. The angina is infrequent, predictable, and triggered by one specific activity. So the simplest answer is a spray before he plays golf. Why load him with a daily tablet for a pain that comes once a fortnight? Metoprolol, he has asthma, bronchospasm risk, and his blood pressure is already 110/80. So a regular antihypertensive type drug may drop it further and make him dizzy. Revascularization for pain once in 2 weeks in a small distal vessel. No, Nicorandil, that is for refractory angina, unnecessary escalation. And do not tell him to stop playing golf. He should continue regular activity and get smoking cessation and cardiovascular risk factor advice. So notice that what all four questions have in common. The answer was hidden in the history and the comorbidity, not in a fancy test. Now, let me show you something. This is our revision note for this topic. Look carefully. There are no questions here, only the recommendations, only the concepts, definitions, cutoffs, first line drugs, contraindications, dosing. Everything you just spent half an hour or I think more than 1 hour learning is here on a couple of pages. The idea is simple. In the last few days before your exam, you will not have enough time to open therapeutic guidelines, then MOTAC, then the ACS guideline, then your notes. You will need one page per topic or a few. This is that note. And this is why I say our class notes are gold. We have already done the searching for you. Every line has been checked against the Australian source. You will not need to open a single guideline yourself. No confusion about which country's protocol to follow. It is all Australian. It is all in one place. It is worth mentioning that I'll take ECG and cardiac pharmacology masterclasses, which will be part of the course. So this clinical overview or revision note is just part of the main note. I just wanted to show you how it will look like. And thank you so much for joining today. I hope you enjoyed the session. And if you have any question regarding the course, you can feel free to contact me.